Okay, let's discuss seizures. Of course, we're talking about the brain when we discuss seizures. The brain actually weighs about 3 pounds, and it receives about 30% of the cardiac output, which accounts for about 20% of the body's oxygen consumption. So, it's a hungry, high-demand organ. And it does not cope well with deficiencies in oxygen and glucose or blood flow. It does not store energy like other cells in the body do. Seizures are among the earliest known and still least understood afflictions, ranging everything from head injury to hypoglycemia. Your nature of consciousness, your arousal, awake state, it's mediated by the reticular activating system. We discussed that in an earlier chapter on altered mental status. Can exist independently of awareness. I know a few people like that. Awareness provided by the cerebral hemispheres. We discussed that somewhat in the stroke lectures. It gives you awareness of self, your surroundings, and response to surroundings. The apparently awake patient is without awareness of the environment or normal response. Keep in mind that the patient may be experiencing a type of seizure rather than a mental illness or a drug high. Seizure can occur at any time in the brain. It can be injured, deprived of nutrients, or just purely irritated. Determining the cause of a seizure depends on accurate observation and description of the patient. Seizures can be trauma or a medical cause. Some quick anatomy for you. The cranial anatomy. There's 300 billion nerve pathways inside there. And as we see here, we have this cutaway version. The cranium, the dura mater, the arachnoid membrane, and the pia, sometimes referred to as the DAP layers. So dura, pia, and arachnoid here. They're in different order, actually. The cranium and the brain, of course, inside, what we're talking mostly about. And then just a little further down here, here's the brain stem where it drops through the foramen magnum, and then there's your spinal cord. Regions of the brain. Here we have the cerebrum, cerebral hemispheres, cerebellum, brainstem, and then we have an enlarged part here, part of the diencephalon, the thalamus, hypothalamus, notated there, with the midbrain, the pons, and the medulla oblongata in the brainstem itself. All right, some classification and terminology. We have generalized seizures, which involves both hemispheres, possible loss of consciousness involved with these. And then we have the absence seizures, which are generally under the age of 20. They have a sudden loss of awareness, but they usually have a prompt recovery of normal awareness after some time and no recollection of the event. I believe this is called daydreaming, or here an absence seizure. All right, moving on. Then you have your classic tonic-clonic seizure. The second major classification of generalized seizures is the tonic-clonic seizure, just as the term absence seizure describes the absent look of the patient may exhibit during the seizure. The tonic-clonic describes the motor activity seen with this type of seizure. The fish out of water, everyone has seen that. The tonic-clonic seizures are among the most dramatic medical events seen in the field. There is a rapid loss of consciousness because of the involvement of both cerebral hemispheres. Following this, the patient may produce a loud cry. This cry often scares bystanders because they think the patient is experiencing pain. Actually, in reality, the cry results from a forceful expiration caused by the abdominal and thoracic spasms. All muscles of the body can be affected during this period. Respiratory muscles, neck and facial muscles, and muscles of the upper and lower extremities produce some of the most visible signs during this phase. The respiratory muscles will become paralyzed also at this point. Extremities can become fixed in an extended position. The degree of extension and length of the tonic period depending upon the intensity of the seizure. The tonic stage will give way to the clonic phase of a generalized seizure. The clonic activity will produce a violent jerking of the head, thorax, and extremities. So I'll give you a moment to think about that one for a minute. The tonic clonic phase, contraction and relaxation of opposite groups, motion will slowly decrease in the number but not in strength. Injuries, of course, to the tongue, which you all have seen. Long bones are a little more rare, and the extremities may occur. The clonic movements can injure the patient from the rapid and powerful alteration and contraction, reaction injuries to the tongue and long bones, as mentioned there, and can last for as many as 3 to 5 minutes typically, but even up to 30 minutes. These patients usually have a retrograde amnesia, so they do not recall anything about the seizure or the events. Then there's the postictal phase, and this is different for every person. Phase in which the period of time in which the patient regains consciousness. This extreme tiredness, length of this phase depends on the length and intensity of the seizure. And again, they will usually have some degree of amnesia. The status epilepticus, the seizure that lasts 30 or more minutes. Multiple seizures where the patient does not regain consciousness is clearly some terminology, some definitions for you. May result in permanent brain damage or death if this is not interrupted. So let's get into some quick pathophysiology. Abnormal excessive discharges of cerebral neurons trigger a 250 times normal ATP consumption and a 250% increase in cerebral blood flow, the 60% rise in O2 consumption, and a 20% increase in lactic acid. Seizures can be idiopathic or secondary to other disorders that may fall into the following basic categories: a CNS injury or dysfunction, a metabolic disturbance, or an infection. History. Need to do a thorough history on seizure patients, even if they're frequent flyers. Mechanism of injury and pattern of mentation. Their physical exam, and then their neurologic exam can be the respiratory signs, level of response, ocular signs, sensory and motory function. All right, your differential diagnosis of seizures can include some of these things. This is a start of this. CNS injury or dysfunction, a medical dysfunction like a stroke, unilateral facial finding, ocular signs, hemiparesis. Generalized signs may occur late or if the insult is profound. Let's back up a moment there and look at that last bullet there. Generalized signs may occur late, or if insult is profound, signs can occur early. We've talked about stroke already, and we will in the future, but current therapies are effective in treating stroke patients, but very dependent on time to treatment, as we discussed with TPA. Some metabolic disorders: hypoperfusion, hypoxia, hypercapnia, and even hypo or hyperglycemia. Things you can actually assess through history and perhaps even reverse or treat in the field. When we talk trauma to the brain, there are 4 main traumas that can be considered: structural damage, free blood, scar tissue formation, and hypoxia. These can all occur from medical issues like lesions and tumors, and like we mentioned a moment ago, strokes, and trauma, or the classic blow to the head. Tumors and lesions are usually slow in growing and present no or few outward signs and symptoms. They usually are diagnosed with a CT scan or MRI and then related to you as a part of the history. So that's something they probably already knew about, essentially, is what I'm saying. Some more metabolic disorders. Electrolyte disturbances are highly irritating to brain tissue. alcohol withdrawal, poisons, abnormal metabolite levels. Let's discuss electrolyte disturbances just a bit more. Obviously, electrolyte disturbances play a big role in homeostasis. So some of the levels we're talking about would be hypocalcemia or a hyponatremia, even a hypomagnesemia, and rarely even a hypokalemia. So all of those electrolytes being out of balance can cause a highly irritating disturbance to cause seizures. Probably the most common serum deficiency encountered in pre-hospital setting is hypoglycemia, obviously. The brain is very dependent on sugar, and if it's low on fuel or low on that sugar to burn, it will become irritable and can create a seizure. Excessive levels of sodium, or the hypernatremia, can occasionally produce seizures just as low levels do. As you can guess, maintaining a perfect chemical balance is difficult, but the consequences involved with fluctuations are, of course, very serious. The brain responds poorly to deficiency of oxygen or glucose, excessive waste products, or electrolyte imbalances, as well to insults resulting from edema or hemorrhage. Many drugs, both illegal and legal, are known to produce seizures. With some therapeutic medications, seizures may manifest as a toxic effect. Therapeutic medications that commonly have this side effect are aminophylline, lidocaine, phenothiazines, fistotigmine, tricyclic antidepressants, and certain antihypertensive medications. Illicit substances such as cocaine and hallucinogenic drugs such as PCP have been known to cause seizures. One of the most common causes of seizure activity is a sudden withdrawal from alcohol and or an illicit drug, a medication, or any other substance. A sudden halt or decrease in a dose of antiseizure medication is one of the most common causes of seizure activity, especially in status. Patients who take diuretics to manage hypertension and congestive heart failure can develop a severe electrolyte imbalance like hyponatremia, can cause decreased levels of consciousness and muscle weakness. Hypocalcemia's effect principally neurologic, with depression, muscle spasms, and laryngospasms. Hypomagnesemia causes lethargy, nausea, and vomiting, and tremors. Misuse of many types of illegal drugs, as well as prescription over-the-counter drugs, can also have an observable consequence. A number of illegal drugs such as crack cocaine, PCP, amphetamines, and others lead to generalized hyperactive states. So here's a list of some of the anti-seizure, anticonvulsant medications that the sudden cessation of these things could cause a seizure to precipitate. So there's a list of these, and these are always changing. So this list is not complete to say any means, but there's an example at least. All right, some infectious disease causes for seizures would be meningitis, a viral or bacterial infection of the meninges, very common in the younger population. Meninges is the inflammation of the, meningitis is the inflammation of the meninges that cover the spinal cord and the brain, most commonly caused by bacteria or a viral infection. Bacterial meningitis is the most severe form. The inflammatory process associated with meningitis has several effects, such as fever, irritation from chemicals of inflammation, and increased intracranial pressure that all dispose to seizure activity. Although meningitis is an inflammation of the meninges, encephalitis is an inflammation of the actual brain tissue. So encephalitis can be caused by a variety of pathogens, or that can be secondary to another disease, such as with meningitis. The inflammation can stimulate seizures also. Recent study in treatment of infectious diseases has progressed very rapidly. Today, infectious diseases are not as life-threatening or debilitating as they once were. However, infectious conditions such as meningitis and even encephalitis can still be very serious. Patients with meningitis and or encephalitis present the same array of possible symptoms, including elevated temperatures, headaches, decreased level of consciousness leading to coma. Signs of irritation of the meninges would include the photophobia, dehydration. General treatment for a patient with suspected infectious etiology of seizure would be as follows. Always consider body substance isolation, administer high flow oxygen based on local protocol, and initiate appropriate monitoring like pulse oximetry and cardiac monitoring. Of course, IV medications are not likely, but an IV would be wise to have. They have similar symptoms: the fever, headache, loss of consciousness, coma, nuchal rigidity, photophobia, and dehydration. They both share those. You're seeing sizeup. Once you have ensured your own safety, remove any obstacles that could injure your patient or your partner or yourself. Still seizing or not is the first priority of care for a seizure patient is aggressive and vigilant airway management. Nasal airway might be necessary, suction as needed, high flow oxygen, and be ready to ventilate. Into your sample stuff, signs and symptoms: confusion, bites the tongue, or bites in the mouth, any incontinence and evidence of a fall or any bystander's history can help fill in the blanks there. Whoop, went one too far. Let's let this video play here. Let's see if this works.
For more information about seizure first aid, always visit www.epilepsy.com, and under our Get Help channel, you'll find a whole section on seizure first aid and safety.
Okay, little informational video there, more for seizure patients, but I thought I'd share it with you nonetheless. All right. Medications that they take: consider underdosing or the non-use of prescribed anticonvulsants. So maybe they've underdosed, or maybe they haven't filled their prescription in a while. Consider seizures as okay. Past medical history: probably somewhere in their history is a history of seizures, maybe a brain injury or a disorder. Obviously hypoglycemia and diabetes or any other kind of medical disorders. Last oral intake: anticipate any sort of vomiting. Obviously people eat and then have a seizure. So be watching that. Airway management is key. Remember from a few slides ago, airway management is #1 priority. Events leading up to the illness: obtain any sort of history from the person. Is there any fevers or any recent contact with someone else who was sick? Maybe have to consult bystanders on this one too. So assessment and management: stop the seizure, prevent a reoccurrence. Obviously your ABCs. This is still airway, breathing, and circulation. Right now, administer midazolam. This can be IV, as it says on the screen there, and I failed to add intranasal too. IM is just not something we would normally go with the intranasal route. So I left intranasal off by mistake, but we don't need to have IM on there. This slide also has lorazepam because we're talking about benzodiazepines. So midazolam, diazepam, and lorazepam, all cousins in the same category of the benzo category. All are sedative, have a sedation effect, and are the ones most likely chosen to stop a seizure, especially in the emergency setting. And there's plenty of anecdotal stories out running around about which one's better. Most of the studies and research papers indicate that Midazolam is just a hair better than most. So probably the most commonly used one is the Versed or midazolam. Investigate and treat any etiology like blood glucose issues. Consider D50. Most of us anymore aren't carrying thiamine, but there is a potential reason for that. Okay, any questions? Feel free to send me an email at jprosser@myncad.com. Thank you. Bye.